So I'm excited and delighted today to welcome to the podcast Jacqueline Piasta. She's a women's health nurse practitioner and national certified menopause practitioner. With a career spanning 15 years, she has been the recipient of multiple esteemed acknowledgments, including being voted top 3 nurse practitioners in the state of Arkansas in 2022. She serves on multiple committees for various national organizations and most recently planned the Menopause Summit, a virtual menopause conference that hosted over 700 nurse practitioners. She has spoken out about menopause, wellness, and midlife concerns on the national level. She lives in Atlanta, Georgia, where she owns a midlife and menopause clinic, Monarch Health. I'm so excited to have you here. I've been watching you on social media. Thank goodness. It's one of the benefits of social media is being able to connect with other like-minded practitioners. And I'm so excited to have you here today.
Well, thank you. Thank you for having me. I really appreciate it. And yes, social media, it is a funny world that we live in. And it's funny when I have patients that come see me from social media, they always say, I feel like I know you. And I'm like, well, you do kind of know me. um, but it does sort of connect us because I feel like we're out there and people are searching for us. And this is one of the vehicles that we can be connected and sort of build a platform around our mission.
Yes. And I feel like, especially in midlife women's healthcare, if we didn't have this platform, I don't think we would be where we are today on the precipice of real change and things that are going to benefit women to come in the near future.
I 100% agree with you there. I think this has for sure catapulted it. It's been a major catalyst in getting the message out and spreading the awareness. I mean, even just all things recently that we've seen in women's health, the movement towards, more awareness on female pain and procedures in a gynecologic office and just various conditions. So don't get me wrong. It's social media I have a love hate with it because it is so in taxing, but I think it's a force for good very much.
Yes, yes, for sure. So tell me a little bit about your education and your career path thus far. What brought you here?
Sure. So I like to say that I sort of started my career in medicine when I was little. My mom is actually she's an infertility doctor, but she's on the side of the lab. So I was that weird kid in elementary school whose mom made test tube babies. And that's when we called them test tube babies. And so I was in scrubs and in the IVF lab from the age of 6 years old, looking at embryos and just sort of followed in her footsteps and worked every job in that office. I filed old school charts and did spreadsheets and stocked cabinets. And then when I went to undergraduate at Vanderbilt, I was well on my way to go to medical school to actually be a psychiatrist. But I just had a really great student advisor who led me on a different path. And she said, why don't you look into this nurse practitioner thing? I think this would be a really good fit for you. And I did. I actually didn't really have a lot of experience with what the nurse practitioner career field was like, but it actually did fit me really well. And so I went to NP school at Vanderbilt as well and stayed on there and went straight through into my master's education there. And I got out and was hired by a wonderful pair of 2 female OBGYNs in a larger OBGYN practice. And I practiced very standard bread and butter OBGYN for several years there. And we followed my husband's Air Force career and moved yet again to another OBGYN office. And then we finally landed in Little Rock, Arkansas, which is where my menopause journey started. I was actually staying at home with my daughter, and I was pregnant with my other daughter, and I was taking a year off from being a nurse practitioner. And I was sort of a job fell in my lap. It was one of those right place at the right time kind of things. And I was offered a position with a menopause gynecologist. And I sort of laughed at the idea of it. I said, this is insane. I've never heard of something like this before. And of course, we were all indoctrinated to think hormone therapy was bad and evil. And we were going to kill our patients if we gave it to them. And I sort of just thought it was a joke. But the physician was very well respected. And we got along really, really well, and we still have a great relationship today. And it started from there. And I didn't know a thing about menopause other than not to treat it. And it just was so infectious. once I sort of helped one woman feel better, and then the next, and then the next, and then you learn a little bit more about the anatomy and physiology of this part of life. It's really infectious. So that's a long answer to your question. Sorry for the ramble on.
No, that's great. And it's interesting that you were initially going to do psychiatry and then you ended up being a nurse practitioner, and then it led into working with OB-GYNs. What made you decide that women's health was for you versus psychiatry?
I wanted to talk to people. I just like talking to people. I like really helping and talking people through their issues. And I really wanted to be a guidance counselor, to be truthful, but my overbearing mother was like, guidance counselors don't make enough money, so you need to go do something else. And she's like, you're never going to pay back your Vanderbilt student loans being a guidance counselor. And anyways, all jokes aside, I don't know why I didn't go into like psychiatric mental health nurse practitioner. I just sort of, probably it was because of growing up in my mom's clinic and just always being around women and being around the nurses, working in an MA position and different positions throughout that office and working with the nurses and the physicians and just seeing like how impactful, how you can help women in different phases of their lives and the complexities surrounding it and the female body and the changes. And I think really that was it. Just kind of took me on a whirlwind there. But
yeah, well, and if menopause care fell into your lap, now that you've been in it for a while, what do you see? What do you recognize in the menopause patients as opposed to the traditional OB-GYN care? Like, what are some things that you recognized in them?
From a clinical standpoint, I feel like probably one of the issues or one of the reasons why we are so far behind in our treatment of menopause, because truly when you think about menopause conceptually from just a bare bones physiologic standpoint, it's not very difficult. I sometimes tell my patients, it really can just be as easy as when you go see your endocrinologist and they tell you, hey, your thyroid isn't functioning very well. It's actually pretty sluggish. Let's put a little thyroid hormone back into your system and see if we can tweak it up. Now, of course, there's nuances and everybody's different and there's a lot more complexities to thyroid care than that, but generally speaking. And for menopause too, it's the decline, the aging process of your ovaries. We are outliving our ovaries twofold now. And it's that inevitable decline that we are outliving. So it makes no sense why we wouldn't want to replace some of that with because of the benefits that these hormones provide us. Just like thyroid hormone provides such benefit in our body, so does estrogen. And so I think one of the main reasons why it's so difficult is women are very different. Every woman is different from one another. Their experience of menopause is different, and they require more time and attention than maybe stereotypically our younger patients, although I think maybe they're just can get dismissed a little bit sooner. We have some pretty bad statistics around average diagnosis of certain women's health, average years to diagnosis. But I think that menopausal women require a little bit more time, and our current healthcare system doesn't really accommodate for that. There's a lot of symptoms, there's a lot of nuance, there's a lot of things that go into the menopause experience, and it's sort of like a snowflake. Every snowflake is a little bit different. And what treatment you opt for is not going to be the same as your friend at lunch or the woman sitting next to you at the stoplight, those sorts of things. So maybe that's what I see is just how nuanced menopause care needs to be as opposed to maybe some other areas of women's health. But we could probably argue that too, maybe for another day.
So how does you have a practice in Atlanta, and then you also offer telehealth services. So how exactly does a telehealth menopause practice work for the women out there who've never heard of it before or don't understand how they could reach out to a telehealth practitioner?
I love telehealth, and telehealth really we've had telehealth around for a very long time. It's just that insurance has really restricted our abilities to utilize telehealth for very, very long. I mean, it was really preserved for very rural areas or certain mental health usage. When COVID came, that was actually one of the maybe more silver linings that came out of COVID was the increased utilization of virtual care. So virtual care for menopause actually works really great because usually we don't. Now, there are some exceptions. Of course, you should have an established relationship with a gynecologist because there are things that can arise in menopause, such as bleeding or pain or vaginal dryness and other genital symptoms that we don't just want to brush off and assume they are one thing or another. But for the most part, symptoms of menopause tend to be rooted in cognitive issues, so brain fog and memory and concentration. There are also temperature dysregulation and joint pain and things such as that. And we can talk about that all in a face-to-face video conversation, such as a Zoom call. And different telehealth providers use different platforms, but they all look like a Zoom call, essentially. And usually when I see patients, we sit for an hour and we go through history and talk about all the way back to puberty and through your pregnancies and what were those like and what has your journey through your hormones been like up till now? And when did your symptoms start? When did things start to get funny? When did your husband start saying, or your spouse start saying you're more moody, or your teenagers are saying, Mom, what's going on? And so we go through all of that. And then usually, just depending on the provider that you're seeing or the practitioner that you're seeing, they can order labs if you perhaps need labs, and then meet back with you and kind of go over things in a way that makes sense and develop a plan of care that makes sense for you. So the biggest thing that I love about telehealth is it increases access to menopause care, because we know that unfortunately the vast majority of healthcare practitioners out there, whether they be physicians or advanced practice providers, tend to be very undereducated about menopause and menopause treatment options.
Yeah, I remember in pharmacy school, I don't recall actually having any discussions around menopause at all. There would just occasionally be a patient in a therapeutics case that was on Prempro. And I was in pharmacy school in 2001. So
Yeah.
I saw the complete, the shelves were constantly being switched over with the hormones. And then all of a sudden they just collected dust in the middle of my pharmacy school training. But I think that it just wasn't talked about. And I know when I talked to my husband about his gyne experience in med school, it was more about, pap smears and delivering babies. And it wasn't talking about women in middle age. So I think hopefully that'll be changing for, educating practitioners in the future. But for right now, having telehealth options is pretty impressive. I know I have a lot of women who come to me very frustrated that they've gone to their OB-GYN and they feel dismissed with, here's an antidepressant or something for sleep, try breath work and therapy. They don't talk at all about the opportunity for hormones. Are those some things that you've seen? Like what are the things that you're seeing in our current healthcare system that you find is broken?
Well, I think you hit the nail on the head right there. It really starts from the beginning of our medical or respective medical, nursing, pharmaceutical trainings. I think that women are getting a lot of mixed messages. They are also feeling like they're being sort of put against their healthcare providers or practitioners, and where they'll hear or see one thing from a menopause expert or a menopause specialist who might be on social media, such as myself or some of my colleagues, and then they'll go all excited to see their OB-GYN or their nurse practitioner that they have seen for many years, and they'll get a very different story in that office. And let's just say by the small, thin chance they actually see their regular GYN, practitioner and they do get hormone therapy, then on your kind of end of things, Victoria, we even see that further barrier. So they've already hit somewhat of a barrier at their regular GYN office. And then they go to the pharmacy, and pharmacists are also undereducated about hormone therapy and types of hormone therapy. There's inappropriate labeling on our prescription hormones that is all encompassing. We have a box warning on our hormones that all hormones cause increased risks of various health concerns. But unfortunately, the data and the research doesn't support that all hormones do that. And so pharmacists then add another layer of confusion, and patients pick up, let's just say, their vaginal estrogen cream, which has no risks associated with it whatsoever. And they're educated by so-and-so. And so it's just this constant information overload, but it's kind of like too many cooks in the kitchen, sort of. I'm a big analogies person. And there's a lot of different messaging going on. We do know, and we've actually have in the last few years have some data. Actually, the best data that we have is out of the Mayo Clinic. Dr. Kling and her associates did a study in 2019 that interviewed full residents at the Mayo Clinic, so one of the top healthcare facilities in the nation. And they interviewed internal medicine doctors, family medicine doctors, and OBGYN doctors currently in their residencies, and asked them if they felt comfortable treating menopausal patients. And 7% of them said they felt comfortable treating. And these are the people that are treating these individuals, or should be treating these individuals. And so, however, the light at the end of that tunnel was that the vast majority of them, and I can't quote an exact statistic on that, I think it was upwards of 80, maybe even 90% of them stated that they felt it was important, but they didn't feel comfortable. So we see a glimmer of hope with feeling like it's important, but a lack of education. So it's really that education piece that needs to come up, and getting these labels off of these hormones that don't serve patients. Because what ends up happening is these women go to their primary care practitioners or their OBGYN practitioners, and they are given antidepressants and sleep medications. If we even want to go deeper, they're given blood pressure medicines and blood sugar medicines. Everything under the sun, we even see symptoms like nausea and GI upset. So they're given meds for that. We see joint pain. So they're given meloxicam or other nonsteroidal anti-inflammatories to help with their joint pain. They're having memory loss or poor concentration. So they're being put on ADHD medications. And we just see this rampant use of all these various other medications, and an avoidance of hormone therapies, which for several years now have been the recommended first line therapy for menopausal symptoms by the Menopause Society. And that's kind of the overarching governing body of our menopause space. So it's not all bad, but we definitely have a lot of work to do still.
Yeah, I think, when I renew my license with the boards that I am registered with, we have specific requirements per given states. So I might have, I had HIV and AIDS education for Washington, and I had end of life care in Oregon. So wouldn't it be great if we were all given some sort of CME requirement that was menopause care based on the standards of our menopause society in this country?
My God, it would be so nice. Actually, Dr. Mary Claire Haver, everybody knows Dr. Mary Claire Haver. She's actually she's quoted that. God, I'm sorry, Victoria. I totally lost my train of thought. What the heck was I saying there? We're going to have them.
Yeah.
What were you just saying? I totally listen.
Oh, the CMEs requiring a CME in menopause care.
Okay. All right, we'll pick it up again. Okay, so Dr. Mary Claire Haver, everybody knows Dr. Haver. She's very, very well known menopause doctor on the social media space, she has quoted, and I believe in her book, that the OBGYN exam, like the board exams to keep the board license for OBGYNs, they don't have a menopause section. OBGYNs are every couple of years, they have to keep their boards up. And the same for nurse practitioners. There's not women's health nurse practitioners, not a dedicated section to menopause. It's just sort of sprinkled throughout like general care of a woman. And you just heard me say earlier that, one of the main differences between a menopause appointment and maybe like a contraceptive appointment that I would do with a 16-year-old is that one probably only needs to be 10 minutes and the other needs to be nearly an hour. And we don't, so we clearly, we're not even re-educating the people out there who were around when you were in the pharmacy and the hormones were hot on the shelf, but then they collected dust. These are the vast majority of clinicians that are in practice today were either practicing when the Women's Health Initiative trial study results were first released, or they were in medical school, residency, some form of nurse practitioner school, some form of medical training. And so we also we're not doing a good job of educating those currently studying medicine and nursing. And we're also not doing a good job of re-educating or trying to get people up to speed. And for those of you listening, I know I kind of brushed over the WHI, but that stands for the Women's Health Initiative trial, which is the largest study ever done on hormone therapy. And it was actually meant to study whether or not, we were studying older women in that study on hormones. Within a couple years shy of when it was supposed to end, they initially thought that there was an increased risk of breast cancer, and it passed their sort of statistics threshold for that. And then it was that one thing that ended up totally ruining it. And the hormones collecting dust on your pharmacy shelf. All women were told overnight, don't use hormones. All physicians and nurse practitioners and PAs were told, don't you dare prescribe it. And now we know, 20 years later, that data was very, there was some good data that came out of that study, but the data specifically to the breast cancer risk on hormone therapy was vastly over exaggerated. And actually ended up only being one additional case of non-fatal breast cancer per 1,000 women as compared to the placebo. So anywho, all that to say, I didn't mean to just brush that over as if it was common knowledge what that was.
Well, and that was actually going to be my next question was, what is the WHI study and what did it show? And one of the things that I kind of wanted to make sure from a pharmaceutical standpoint, people understood when they're listening. If you haven't heard about the study, they use synthetic estrogens and progestins, which are not chemically the same compound as the hormones that are produced naturally in your body. So there's a conversation around bioidentical or body identical hormones, which we can talk about a little bit as well, because I kind of want to talk to you a little bit about the compounding pharmacy versus what's FDA approved. But so for people who don't know about the study was done with those synthetic hormones. And now we have options that are actually the same chemical compound structures that are produced in your body. So it's replacing with the same thing that you would have produced yourself if your body was still at the same functioning level of premenopause.
Exactly. Yeah. So, I mean, the WHI is very important. If it had been utilized in the way that it was supposed to be utilized, which is looking at whether or not we can safely administer hormone therapy to women well beyond menopause, and the results should have never been extrapolated or used for whether or not we determined whether hormones were safe in younger women. And we also ended up utilizing, like you said, the wrong hormones. So when we look at estrogen, the WHI used an estrogen called Premarin, and it basically is estrogen that is extracted from the urine of pregnant horses. And Premarin contains 9 different types of estrogen. Humans produce 4 different types of estrogen, 3 when we're not pregnant, a 4th when we are pregnant. And Premarin has 9 different types, and several of which are known to increase our risk of thrombosis. And then when we add the fact that the Premarin was given through the mouth, which then goes through the liver, which then further elevates clotting factors in women that were already well beyond menopause, hadn't been on hormone therapy, and likely already had some degree of atherosclerosis, or the thickening and hardening of their arteries built up, plaque built up in their arteries, then we were, it's kind of silly and ridiculous that we didn't expect or we didn't, foreshadow that something might not go right there. The second hormone that they used in the WHI is Provera, or medroxyprogesterone acetate. Provera is a synthetic progestin, and it's linked to potential, a very, very, very small at this time risk of breast cancer, but not zero increased risk of breast cancer. And it's also been linked to potentially some less favorable things in the clotting world as well. It's linked to increased risk of depression. It's funny, the studies they say, well, hormones can't help women sleep. Well, most of the studies that we've done on that are on progestins, or on a synthetic form of progesterone that does not work like natural bioidentical progesterone, which can help women in menopause and perimenopause sleep. So these hormones, they use the wrong hormones, the wrong way to use the hormones in that woman. I'm not opposed to all orals, just in women well beyond menopause. So they use the wrong drug, the wrong route, the wrong time, the wrong individual. And, things happened, and we didn't appropriately evaluate the data, and we didn't appropriately get the message out on who the results can actually be applied to. So yes, that's very important to make that differentiation between, because right now, the vast majority of us in the menopause space prescribe what we call bioidentical hormones, or estradiol and micronized progesterone, tend to be the more favorable hormones to prescribe.
Yes, I personally love my micronized progesterone at bedtime.
I have to take mine. I mean, I'm only in my late 30s, but perimenopause has hit me hard. Maybe it's just a guilty of association at this point. But it works wonders for me. So yes, I think too long are women sort of kept from the secret. It's like the cheapest best kept secret, that's the worst kept secret kind of thing.
Yes, and you're talking about how you're younger than the average age of 50 for menopause. Are you seeing a lot of younger women in their late 30s, early 40s in your clinic that you're prescribing hormones to? Some women don't understand that perimenopause can happen for a long time, and it can start early, and that might be the period when hormones can be really beneficial.
Yes, 100%. So it's the myth of age, right? The myth that we have to be a certain age. If I had $1 for every woman that came to me and said somebody told them they were too young for menopause, or patted on them on the shoulder and said, "Oh, sweetie, that's not what's happening here." But the average age of menopause in this country is 51 and a half, which means 1 year without a period, meaning that your ovaries have decided they are not working anymore, and they're not producing enough hormones to give you a period. And of course, there's other different flavors of menopause, like surgical menopause and chemically induced menopause and premature menopause and all those things. But generally speaking, the average age is 51. The average age range, and this is, I think, where people get it wrong, is we're just waiting and holding out for like the 50s to come so that we can validate our experience of feeling very different in our body. But the average age range of menopause is 45 to 55. So it's still considered normal to go into menopause, experience menopause at 45. And the average duration of menopause symptoms can span anywhere from 4 to 14 years. So let's just surmise that you're 44 years old or 45 years old, and that's when you hit menopause. Then you very well could have started experiencing your symptoms in your early 30s. Well, most women in their early 30s, if they report that they're not feeling well, or they're not sleeping at night, or their moods are off, or most healthcare practitioners are not going to say, oh, you're going into perimenopause. Here's some micronized progesterone to help, support your hormones through this time. They're going to say, okay, here's the pill, or here's an antidepressant to boost your mood, or here's a little sleeping pill to get you sleeping at night. And so they completely brush over it because they don't connect the dots, because our brains are so stuck on this 50 number. And we don't recognize that the span can start much earlier. My symptoms, I think, started when I was 35, but I also do this for a living. And so I recognize those changes when I was waking up drenched in sweat and I couldn't sleep at night and I couldn't concentrate anymore. Like I probably had very high functioning ADD my whole life. But as Victoria was so patient earlier in the interview, I completely spaced and forgot what I was saying. And those symptoms have gotten so much worse the older I've gotten. And I'm not even anywhere near what we would traditionally think a menopause age should be. So, but I do think that I don't know if it's the power of social media and the power of information, the ability to touch information a lot easier and access it, or if it's that women in general, we're just more unhealthy. Our gut microbiome is more unhealthy. We have higher rates of obesity, insulin resistance. So I don't know if these are things that are contributing to a earlier experience of menopause, or is it just the awareness? And it's also, I think I would be remiss not to mention also this more awareness around not always wanting to rely on the birth control pill. There's a lot of, and I don't want to vilify the birth control pill because I do think it is a good tool for certain situations and it works really well for certain individuals. But I think there is sort of this increased or heightened awareness around the birth control pill, and that not all women want to continue utilizing this. And so they're looking for other answers.
That's true. I remember hearing from someone that, it's a bell curve. And so that's an average. And so there'll be people on the early end of the bell curve and there'll be people on the late end. And my nurse practitioner herself said that, she has a patient who's 59 and still has a period. And I don't know. I'm 43. I'd much rather be on the early end than on the late end personally, but it can affect everybody so differently. And I think that's one of the things that for clinicians, I know going through our therapeutics course, we were taught this is how a disease presents. This is how you treat the disease. These are the labs to monitor the disease. And, and this is the next step. Well, menopause isn't a disease. It's a transition of life. It shouldn't be categorized as a disease, but there's so many different variations of how it's going to present and at what time it's going to present. There aren't really, you talk about labs. What are your feelings of hormone lab testing and how do you utilize those or not in your practice?
Yeah. So this is actually a very polarizing topic, I think. Labs. There's all sorts of labs. I will be the first to admit when I first started out my menopause practitioner journey, I didn't know what the heck I was doing. And I relied on saliva hormone testing. I did saliva hormone testing with my patients. And then I very quickly learned, and I think if anything, it speaks to my willingness and openness to seek multiple avenues to provide solutions and answers. But what I found through utilizing hormone saliva testing was it really didn't give me an accurate picture of what was going on with women's hormones. It just cost quite a great deal of money for women, and it didn't really change my treatment, like the outcomes. Actually, if I followed the saliva lab tests, I found actually patients had worse outcomes. And so there's 3 different types of ways that usually women will come upon a clinician who is going to test their hormones. And one is through saliva, which is, in my opinion, the most inaccurate form. The second way to do it is in dried urine testing, otherwise known as the Dutch test, which is a relatively accurate way of measuring hormone metabolites. But it's very costly, very expensive. It provides a lot of information and a lot of information that a lot of people don't know what to do with or really even need to do anything with. So I always say that's definitely for maybe the more advanced person, or if that's just your personality and you want a whole bunch of information, and you're into that kind of thing, the more functional space, then the dried urine is out there. There's also 24-hour urine collections. Those tend to be very, very, very scarcely used. There's some practitioners out there that utilize them. But actually, my friend and colleague Jill here, she's on the Instagram space as well. She's an RN, and she's introduced me to that. And then the last way is through labs. And why most traditional medical providers or practitioners do not want to draw hormone labs in perimenopause is because our labs fluctuate. Well, yes, they fluctuate, but I like to provide a data point for individuals. So I am never opposed to checking people's labs. It's really no skin off my back. I just, put the lab orders in and I just say, listen, let's take it with a grain of salt, because this might tell us a great deal, or it might tell us absolutely nothing at all because you're in perimenopause and it's a roller coaster in perimenopause. Whereas in menopause, we really can expect you to have no hormones coursing through your vein, maybe a little bit of testosterone, but usually no progesterone and very little estrogen. And so some women just need to see it to be validated and to see that there's nothing there, and to kind of have like what's the before and after shot, I guess, to say. But my preference in menopause when I have people come to me is I usually will wait on the labs if they're fully menopausal. Start on the hormones based on their symptoms and my best intuition. That's kind of one of the things about working with a very astute clinician. And then in 6 to 8 weeks or so, roughly after you start on your hormone therapies, then go have some labs done. See how the body is taking to these hormones and what are the levels and how are things going. I have some level areas where I usually like to stay around, but again, this is a heavily debated subject, and some of my more traditional menopause society people are going to skewer me over this. We all agree to disagree on some things. And I am big on access. And if patients and individuals, if women want to see their labs, as long as they are properly educated on what the lab work is actually providing them, then I'm all for it. I also like to check other labs as well. It's a great time where you get somebody in front of you and you can I try to take that time to say, listen, this is a time where cholesterol levels will start to go up. Oftentimes blood sugar levels will go up. Our vitamin D is usually in the toilet. We're wearing sunscreen and long sleeves and we're inside all day. Certain other, so many women are insufficient in iron levels. I mean, there's just so many other things that I can sort of test for and check. And them coming in for their hormone levels is an opportunity to look at the bigger picture as well.
Yeah, that's true. And it's interesting because you can find an article or you can find, a standard to tell you whichever way you want to go. And so I think that it's really great of you to say, this may not be the practitioner, over here may not say do hormone testing, and this one might be a Dutch test advocate, but this is what my patients need. I think, when I talk Dutch test with women, there are some women who very strongly believe that they want to have that done and they want the data. They're biohackers. They want to know all the information. And that's great. I think it is, it can run upwards of $700 to have a Dutch test run. And so if they're willing to put forth that money and know that this data may not be necessary, but it's something to have if you want it, versus, absolutely no blood work is needed. We don't need to do that. I think that women have been dismissed for so long that if somebody presents with a question of, can I do this? I think that's a great way to lead in.
100%. I mean, exactly. I usually try to dissuade people. If they've come to me and they have a Dutch test, I will go through it with them and help them to the best of my abilities. I tend not to go that far down the rabbit hole with all of that, but I do try to at least know enough about those tests. But I always say, let's try to work on it without that. Like, let's save
Mhm.
that money for a rainy day or a nice pair of shoes or whatever. And if I can't get you better in 3 months, 6 months, whatever timeline you want to, agree to, then we can run a Dutch test. They'll still be there. So anywho, all that to say, I am very big at access and allowing women to make their own choices and providing them with the information, um, and they can do with that how they like.
Yeah. Do you have women who come to you and you try hormone therapy and for some reason it isn't for them, it's not working, or it makes them feel worse, or they have adverse reactions to it?
Yeah, and I think that's really important why we need to keep an open mind as well about various forms of hormone therapy. I think we hear in the social media space, I'll just pick on micronized progesterone for a minute. We hear all these wonderful things about micronized progesterone, and I'm the first to join the micronized progesterone club. It works wonders for me. But there's about 10% of the female population that actually can't tolerate micronized progesterone. It actually makes them feel worse. It makes them feel sad and down and blah and hungover. And I know blah is a technical term, but it just makes them feel weird, for lack of a better way. Or there's even smaller percentage of women that actually have a true allergy to progesterone, and we give them micronized progesterone and they break out in one of the worst hive reactions you'll ever see. So for those individuals, then perhaps a low dose of a synthetic form of progesterone, progestin, for the minimal duration of time through that month that you need it to protect the uterus, if you're on an estrogen therapy, may be the right choice of hormone that for that individual. Just like for someone else, a birth control pill might be a good option for perimenopausal symptoms, and then for another woman, absolutely not. So I think it's really, really important to keep an open mind, because yes, hormones are wonderful and they're super beneficial for a whole number of different things in the menopause and perimenopausal space, but they don't come without side effects. And they don't come without the potential for certain women to respond in different ways to them. Some women on estrogen, they get really bad headaches with it. They get, or they do well on oral and not transdermal. And then I have to advocate for my compounders, because I know this is also a hot debated topic
Yes, yes,
as
it is.
well. And I always like to say it isn't that compounders are not regulated by the FDA. It's just that they have different regulatory pathways with the FDA than a big commercial manufacturing pharmaceutical company does. But like, I myself am actually allergic to the inactive ingredients in micronized progesterone that I got at a regular pharmacy. It's made with peanut oil and
Mhm.
some other things, and that does not work well for me. And I use my micronized progesterone compounded. But I also understand that it comes from a compounding pharmacy, and things are made per single batches. They're made in small batches, not in these large trillions of pills at a time. And so there's different processes that go in place here. The biggest bone that I have to pick with the compounding industry, and it's not necessarily the compounders, it's the clinicians that are educated this way, is that they tell women that the only way that they can do hormones is through compounding, and they've got them on 6 different things, all that cost $40 to $50. And you know and and a lot of times they don't even feel better. They're on subtherapeutic doses or whatever, and they're just being wrongly told that because it's compounded, it's safer and it's more effective. And so again, it's just this knowledge battle that we're in.
Yeah, and I think that just bringing to light for women that there are so many options, and that even if you try something and it doesn't work for you, that doesn't mean you're doomed. You don't get to have hormones, or that, if you do want compounded forms of hormones, that there are opportunities for you, but there are smarter, more economical ways to do things. I think that's really important, and I think that's something that also goes back to that practitioner education piece that we're kind of missing. So I hope that changes a little bit.
100%. Yeah, I mean, it is. And it isn't that, the North American Menopause Society recommends against compounding, but it isn't necessarily recommending against it in terms of, oh, it's all bad. This is where we have to read between the lines with the guidelines. It just means that currently, right now, the evidence that we have, the most robust evidence that we have, supports the standard medications that we have that are approved for the FDA and go through the natural clinical trials that are part of the FDA's process. But there are some individuals that need different approaches to hormone therapy. And in those cases, we take individualized approaches, and perhaps you might need a compounded medication as long as you are counseled on the benefits versus risks of that. But the problem is they have these big societies like the Menopause Society, they have to put out big generalized guidelines for the average person. And for the average person, there is no reason why we cannot take a more economical approach to menopause. I mean, menopause is a $15 billion industry right now. Like everybody who's anybody in the celebrity world has a new supplement out there they're trying to sell for the hormone this and hormone that. And again, I love me some supplements. Go look at my pantry. It's full of them. But this is like menopause doesn't have to be expensive. It just doesn't have to be hard. And like you said, it's the education piece that we're
And
missing.
I feel like we're at the precipice of healthcare shifting for women. But in the meantime, there's this space for marketing and companies to take advantage of the desperation of women that haven't found the care that they need in the direction they want to go. And so they are, we're a demographic that has the spending power. I mean, I think there's research out there that shows that we're one of the biggest consumers, women our age. And so they're marketing that and they're targeting our insecurities, our fears, our desperation, our frustration to make a bunch of money off of something that doesn't need to be so expensive.
Well, and they're also capitalizing off of the big thing that you said was fear, or the myths, as my friend Kelly Casperson says, the myths of natural, the myth of, oh, you're just getting older, so this should be something, you're a failure if you have to use pharmaceuticals. You should, these myths that we have, these standards that we have for women that are absolutely egregious. And so women feel like they should go to these alternatives first. And then if they don't do supplements, then they have somebody saying, well, we have these compounded meds here that are safer and more natural. And so there's this fear around, they feel like let down by the medical institution as a whole. And so therefore pharmaceutical medications also get lumped. And because hormone replacement therapy in the FDA approved formulations is part of that system,
Yes,
it sort of gets a bad. I mean, I have patients all the time. They'll come see me and I'll prescribe them the patch or estradiol or whatever. And it never ceases. They never fails that like 48 hours later, I'll get a portal message. So are these hormones that you prescribe me bioidentical? And I'm like, and of course there are studies. It's a lot. It's coming to see a menopause specialist is like drinking through a fire hose. I'm telling you a lot of things in an hour's time. And studies have shown that people only hear about 30% of what healthcare practitioners say in a health visit. But it's so funny because we still have such this, fear around. It's like, yes, that's what I prescribed you. And it's okay. And I love the questions. It's just interesting.
yeah. Well, black box warnings don't make it any easier
God,
because they get
no.
home from the pharmacy and they're, and those pamphlets. Oh, the pamphlets. As a pharmacist, I didn't even like reading them. But if you get into the pamphlet of anything, it can be intimidating. But then when you add the warnings or, being prescribed testosterone is a controlled substance in this country. And it's not indicated for women unless they're menopausal. And correct me if I'm misspeaking this, but menopausal with the libido issues. They have to be diagnosed with decreased libido and menopausal. So if you're perimenopausal and you get your testosterone checked, or you're interested, or you're having issues with your libido, because that happens in perimenopause as well, then there's no indication for it. So doctors and prescribers can be fearful of it. And then you have to get to the pharmacy. It's a controlled substance. It's not indicated for women. And so then you have that hurdle to jump through. And so, I mean, I just feel like we're kind of banging our heads against the wall sometimes with these things. And so I just hope that these conversations continue so that we can get to a point where we can take that controlled substance mark off of testosterone that's in a
Yes.
pharmacy. I could go buy it in a gym, in the locker room,
Oh my God.
because that's safer.
We need to start manufacturing round pegs for our round holes. Right now we have square pegs for round holes, and we are trying to fit them in. And I mean, that couldn't be any more true for testosterone too, because that's actually one of the areas where I actually tend to rely on my compounders a lot. One, because they actually can make testosterone in a dose formulation that is for a woman, because we have no female dose products for women that are FDA approved. And two, they also, it is so crazy the stigma that women face when they go pick up testosterone from the pharmacy. It's unbelievable. It's the stories that I mean, I can't even make this stuff up. I mean, women are made to feel like they're buying hydrocodone in a back alley. I mean, it's just ridiculous. So, and then you touch on the fact that all of the FDA approved products are formulated for a man. Testim gel, which is the most commonly prescribed testosterone for women, that's one of the FDA male, it comes in a box of 30 tubes. Well, 30 tubes is going to last a man a month. And for women, we use roughly 1/10 of the male dose. Well, that's going to last them a whole heck of a lot longer. But pharmacists are not taught and trained, like they are not told this. They don't learn about, now a bunch of these prescribers are learning how to do off-label testosterone for women, but then we're going to patch together a man's product and use, I mean, it is a nightmare. I mean, it's just the disconnect is so it's really difficult. And then the labels and the warnings and the everything that don't even apply. But to your comment, you were correct. So right now, as a global consensus statement, the best research and evidence that we have to support the use of testosterone in women is for low libido and for those women that tend to be in menopause. And that is what currently is supported. And then we have premature ovarian insufficiency, which is individuals that go through menopause before the age of 40, also benefit. And around that, basically the guidelines say we just don't have enough data and research to support its use universally. Doesn't mean that we can't use it individualized for other women that, we have an informed conversation with about the risks and the benefits. It just means as a whole overarching medical community, we have to go on the evidence and the data that we have to make recommendations. And that's what is out there now.
Yeah. Wouldn't a drug company just make so much money if they formulated and had a product for testosterone replacement for women that was FDA approved? Could you imagine? It's a gold mine. I can't believe they're not doing it yet.
Well, it's really infuriating, actually, Victoria, because they do actually have a female product. It's called Androfem, and it's out of Australia. They're currently trying to, right now, I believe that the drug company is working with the UK to get it over to the UK. But it's why I don't know. I know some of my friends and colleagues in the menopause space that are the bigwig physicians in this area are working and to figure out what the disconnect is. But it's always politics and finances. I mean, it's always politics and financial. So it's somewhere there. It's just above my pay grade, maybe a little bit.
I know. We don't need to get into lobbyists and all those kind of things right now. But that's definitely above pay grade. I forgot that there is a product that's in Australia that's approved for use for women. Wouldn't it be grand if we could get past politics?
God. I would love it. And it's a patch. So easy. Oh my God. I'll just put a patch on.
You can have your estrogen on one hip and your testosterone on the other, and then you're just golden.
Yeah, you'd be great. You sail off into the sunset, and yes.
Yeah, I mean, the women that I've talked to who have gotten testosterone treatment and therapy, they said it's life-changing. I mean, they didn't realize it was the missing piece. And so to deny that to women who want it is really unfortunate.
Women are capable of making their own decisions. They are also capable of knowing when something might not, they can course correct for themselves. And this, I rely on my patients a lot to course correct. I will say, listen, this, I am giving you this dose, but if you don't feel right about it, it doesn't mean that you have to continue using it. And I feel like, again, there's this sort of weird thing where we feel like we can't trust women with their own bodies and their own healthcare decisions. And it's in menopause is no exception. And it's very strange. So I hope we can move past this and let women have more of a voice.
Yeah, well, and I appreciate that when you talk to your patients, you do tell them, see how it feels in your body and see how you're reacting to it, and then let me know. Because there is also still that feeling of, this is what my doctor gave me, and I'm going to take it. And, he knows best or she knows best. And so to have that open dialogue and to be able to feel comfortable with saying, my intuition, my body, I'm just not feeling this the same way that I think I should. Can we do something different? That's the kind of care that menopause requires. So thank you for doing that.
100%. Yes, yes.
So, what is giving you hope for menopause care in the future?
Well, speaking of politics, we do have a huge push right now, a big financial push on Capitol Hill with a bunch of funding that is being pushed. I believe this past week, the actress Halle Berry was in the news up on Capitol Hill with some Congress individuals pushing more funding into the menopause space. President Biden just signed a big women's health funding bill. And so we do have hope. I think, we got to have money to make change. I mean, money makes the world go round. And so I think that my biggest hope is that there is an interest in it, and there is a momentum right now. I think women are sort of like, as the suffragists from back in the days of holding picket signs up. I mean, there is a lot of momentum going, and then also women have, like, we found each other through social media. There is that shared experience now. There's different Facebook groups, several. There's one, Hello Perry and Perimenopause. There's another one called Wake Her Up, where women, it's go in these forums, and these, women can start to sort of look and say, wait, okay, women feel so alone a lot of times during the menopause. Like, we don't want to talk about it. We don't, you can't talk about that. And then when they realize that they're not alone and that the other women are experiencing this or going through that, there's a vulnerability there, but also a power in that vulnerability. And so it contributes to this momentum. I mean, how many women are like going on a cruise for menopause? Well, yeah. They just had one of those, and it was very well attended. So, yeah, that's like, write that down as something I never thought I would ever say in my life, right? So, anyways, all to say, I think there is this momentum and sort of this women seeing that they can connect and their voices are stronger together.
Yes, I wholeheartedly agree. This is not your grandmother's menopause, for sure.
Heck no, no way. No.
Thankful for that. So the last thing I ask every guest, and I ask them the same question: what is one thing you wish to pass on to the women in generations to come? What are your words of wisdom for those up and coming menopausers?
Oh my gosh, this is a great question, but a little bit tricky. I have to get sentimental here because I have two young daughters. They're still in elementary school, and every day I teach them that they matter, you matter, your voice matters, and how you feel matters. And so I think if I have to pass that thing down, it's just understanding not to like beat a dead horse here of what I just said, but just know yourself, know your body, your intuition, and listen to yourself, and know that you're important, and you're powerful, and I always say, not to, you are you, you're the only you, so like, use it wisely. So that's what I have to say. And if you get pushback, then carry on, sister. That's what I got to say.
That's wonderful. So I'll put in the show notes that you can find Nurse Jackie on Instagram. And if you are interested in Monarch Health, there are practitioner availability is in Arkansas, Georgia, Florida, and Texas. So if you're not in one of those states, there are other telehealth providers out there. But if you're in one of those states, she can provide some care for you in that direction. So it was wonderful having you. Thank you so much for talking to me. It's fun. I selfishly am loving this idea that I get to talk to these amazing women and providers in this space and not only amplify the voices, but I get to learn so much and have these experiences myself. So thank you very much for this
No,
hour.
it's great. It's super fun. Yes. And if you're not located in one of the states that I'm licensed in, Victoria, you are totally right. There is a huge network. There's several large telehealth menopause companies out there doing great work. And then I also host and teach a mentorship for clinicians out there to learn about it. So I also have a big database of clinicians all over the country that have taken my course and my mentorship. And also we're a lot of buddies in the social media space. We know each other. So I have people ask me all the time on Instagram, do you have somebody? And if I don't, I will just say I don't. But a lot of times I've got at least somebody that I can connect you to in this space.
Yeah, I feel the camaraderie and the sense that there's room for everyone in menopause care, and I think that it's a great connection of women that is being developed right now to help care for everybody in this generation and beyond. So thank you for what you do. Thank you for the care you provide and the knowledge you're giving to everyone. The fact that you're helping to educate practitioners is gold, and don't stop doing that for sure.
Yeah. Well, I can't keep complaining about it and then not doing anything about it. So, anyways, well, thank you so much, Victoria. It's been a pleasure to be here. Thank you for having me.
Awesome. Thanks.